Floppy iris are a nuisance for a phacosurgeon, and more so especially if the cataracts are reasonably hard. And here is one this case. We can see the cataract which is reasonably hard. It is something like grade 3 to grade 4 cataract, and we can also appreciate that the pupil is not very well dilated. This is the fundus photograph, and we can appreciate it is normal and the surgery has been initiated. Anticipating that this pupil will not be cooperative during the surgery, we have put in intracameral lignocaine as a standard part of the surgery, and we can see that the pupil is something like 6 to 7 millimeters in size right now, and this part of the surgery is being run at twice the speed just to expedite the surgery so that we can reach to the point of interest earlier. A capsular excess is being fashioned, and these cataracts which are brown and in old people don't have elastic capsule, so the surgery and the capsular excess is specifically not very difficult. Making a side port, and by the time we can see the pupil is started shrinking a little bit, and that is again anticipated in such a situation. Doing a hydrodissection, and the key to these surgeries is that fluid flow and the flutter caused by the fluid should be minimum, and for that one has to keep the flow of fluid very regulated and very judiciously used. So we all know that phacoemulsification, the fluid moves because the aspiration tip will aspirate the fluid, and the irrigation is gravity fed, which will come in when the fluid is removed. So if the tip is choked, there is practically no fluid flow. So one can use this trick that once the tip is embedded in the nucleus and there is occlusion, the fluid flow will stop. And here we can see the first primary chop is being performed, and you bury deep into the core so that to get a good purchase, and then you have a full thickness primary chop, which is very reassuring in such scenarios. Removing some of the intruded air bubbles just to have a good view, and these pupils and iris can actually continuously prolapse to the side port, and one has to stop the irrigation, reduce the intracameral pressure, and then deposit the iris back, and this has to be done numerous times. Making the second chop so as to have three pieces of nucleus, and we can see this is again a full thickness chop. After separating the pieces, we have achieved 3 pieces of nucleus after performing 2 chops. Keep on rotating the nucleus, and as we can anticipate, this end of the primary chop would not be complete, so we can complete it right now, and we have separated that. Performing the third chop, which will produce 4 quadrants, and then we can proceed for emulsification. Some amount of iris damage is inevitable in these cases because iris is so floppy that it will simply flow out with the flow of the fluid, especially the side port, which keeps on leaking a little bit because of the manipulation and because there is no rubber sleeve around the chopper. So one has to deposit the iris so that it doesn't get shaft too much, but at the same time, if the pieces have been separated, you can actually pull out the chopper, which will prevent further prolapse of the iris and traumatizing it, as has been done here. So we can see it is single-handed being managed without the aid of chopper, and if we need chopper we can again go inside, but minimal leakage from the side port will keep the iris from getting damaged and meiosis getting progressively increasing. Small pupil requires the one has to manipulate with the chopper so as to bring the pieces into the central pupillary area so that one can emulsify them. At the same time, one has to take care that the end of the process of emulsification there will be some amount of surge which will pull the iris into the phaco tip if the piece has been consumed and there is iris which is very close by. So one has to be very cautious and active at the foot switch so that the moment the piece is being consumed at the end of the emulsification process, one has to lift foot switch so that the vacuum and the pull is relieved. The more you are close to the iris, more are the chances that you may pull in the iris in such a manner. So the unpredictability of the iris behavior at the end of the piece which is being consumed is usually an issue why the iris would be absorbed or pulled into the aspiration port or the phaco tip. So we have casually removed the nucleus, and these nuclei can have small pieces which are hidden here and there underneath the iris, which may be a surprise, and as we'll see in this case also. At this moment the surgery is being done at the pupillary level, or rather in the anterior chamber, which will definitely cause some damage to the endothelium, but this is a better bargain because being close to the posterior capsule means that one can have a risk of posterior capsular tear, which in such a scenario would be a very difficult task to manage and to complete the surgery. These last pieces require special precautions so that the iris is not pulled in because of the surge created and because there is nothing else left in the anterior chamber. Stopping the infusion, repositing the iris, and then it's starting the infusion and coming out. Take time to replenish with viscoelastic, and now we have proceeded for irrigation aspiration. Although we anticipate minimal amount of cortex, but as we can see here, there is a plate of cortex draped over the posterior capsule, especially in the subincisional area. Now one bid is that you go ahead and try to remove it, but with the kind of haziness in the cornea and the small pupil, it's a very dangerous maneuver, and it may cause some damage to the posterior capsule. So better bid is to polish this wisp or sheet of cortex away from the posterior capsule so that it is scooped away to the periphery, and then one can simply proceed with implanting the IOL, and this IOL will provide a good shield so that we can boldly go and remove this cortex without fearing any entrapment of the posterior capsule in the aspiration port. So using this strategy, we have implanted the intraocular lens, which will be dialed in place, and we can appreciate that at this moment the pupil is hardly 3 millimeters in size. Now once we have IOL in place, we can go ahead, use a Y-shaped or a dumbbell dialer which can be used to shift or lift the iris away from the aspiration port and peek behind, looking for cortical matter which is hidden behind the iris. So this is one efficient and safe way. Once we have implanted the intraocular lens, it is much more safer to explore and remove this kind of cortex which is hidden behind the iris tissue. Once that has been removed, we can proceed for removal of viscoelastic, and here we have a surprise. One piece of the nucleus which is hidden behind the iris has popped out, and this cannot be removed using irrigation aspiration cannula, so we have to switch back to our phacoemulsification tip, which is not a difficult job, and we have removed it. So this is always a possibility in these kind of iris which are having a very small pupil. This is the day 1 picture. We can anticipate and appreciate the amount of keratitis it has, which should get resolved. And this is the day 7 picture, where you can see it has resolved considerably. And this is the day 30 picture, which shows a very clear cornea and a good recovery. Thank you.